Hello folks again. Lyle Ashberg, your friendly pediatric orthopedic surgeon and hip specialist, greeting you again from a day on the road. So I'm traveling today, but I thought that I would do a quick recap of our last episode because I've gotten some comments and some suggestions about some things that might have been unclear. And so what I thought I would do is, as a routine, every week I would do a recap of the week before's episode and do it in a way that's more understandable to the average folk. And so if you recall, in the last episode, we talked about the unnecessary utilization of bracing for four conditions that we commonly see children in the orthopedic clinic for. And to remind you, those four conditions were Intoeing, which has three components that tend to result in this presentation. The first one is this thing called femoral anteversion, or twisting of the upper femur bone. The second one is internal tibial torsion, which is twisting of the lower leg or the shin bone. And the third reason that we would see intoeing is because of this thing called Metatarsus adductus. The fourth thing we talked about was painless flexible flat feet, as being a common thing that practitioners are still bracing for, but is unnecessary. And although I said four things, a potential fifth thing is the natural development of a child's leg with growth, wherein they often present with a bowed appearance, and which transitions to an knock-kneed appearance, and finally to the adult alignment. And I got pretty technical on the last one, and I also presented some studies. And I remind you that the reason that I undertook this episode was because there was an article that was published that discussed the fact that despite some very clear recommendations and consistency amongst three of the biggest organizations that are involved in the orthopedic care of children, there are still people that continue to prescribe bracing for these conditions. And just to remind you, those organizations were the Pediatric Orthopedic Society of North America, or POSNA, the American Academy of Orthopedic Surgeons, and the AAP, which is the American Academy of Pediatricians. And they're pretty unanimous in their recommendations. If you go to their websites and look at it, you will see, and I'll put a link to their websites below, you will see that they unanimously recommend against bracing, and in fact, in some instances, they suggest that bracing in children might be harmful or detrimental. So from the top, once again, let me just remind you, intoeing is a very common finding in the child when they start to stand. There are three major reasons that I've mentioned before, none of which require bracing. For the femoral anteversion, the upper twisting of the upper part of the femur, there's a natural progression from the infant up until the adolescent, who then finishes their growth, of a decrease in the amount of anteversion of the upper femur over time. However, in people who are intoers, that tends to be less consistent, and the magic numbers are about age 8 to 10, where that is the natural history or the natural untwisting that occurs with growth. The second reason we talked about was internal tibial torsion as being a common reason for intoeing. And again, the tibia bone is the shin bone, and that internal twisting generally resolves by the time a child is about 4 to 6 years of age. Now, I might have misspoken. In some studies, internal tibial torsion may be the most common reason for intoeing, although that varies between study. So it's unimportant, but what should be taken away is that there is a natural untwisting of the bone that can be expected over time. I also mentioned in my long diatribe about femoral anteversion and some of the studies that were done, that in children who are intoers, there is a tendency for about 60% of these kids to have a natural correction of their intoeing. And I alluded to the fact that in most of those kids, about 80% of them, the untwisting occurs in the tibia, where they would have a general external tibial torsion, which is also, again, the natural or the more normal or more common rotation of the tibia bone. In fact, I also mentioned that the average external tibial torsion in the otherwise so-called normal or more common finding in the general population is about 10 degrees of external tibial torsion. Now, some of these kids will continue to have, may have more or less external tibial torsion, and when combined with persistent anteversion or increased anteversion, you can have this problem called the miserable malalignment syndrome or the knee torsion syndrome, or simply the torsion problem of the lower leg. And in some instances, not many, and I can tell you that in my career I've probably taken care of a handful of kids that required surgical treatment at both levels for this problem, that sometimes have knee issues or sometimes buttock pain. So it is treatment of that particular entity is rare. It does not respond to bracing, and surgery is the definitive treatment. And it oftentimes requires cutting the bone, which is an osteotomy, fixing it, and then fixing it in the corrected position. Again, I will reiterate, we wouldn't intervene surgically in these kids unless they were having symptoms that were refractory to non-operative methods. And in this instance, there may be a role for physical therapy, not to get the bone to untwist, but to improve the muscular coordination of the limb so as to manage the pain. But that doesn't improve the untwisting of the leg. So that needs to be very clear. So, again, these two entities and reasons for intoeing are generally benign, have a good prognosis, and don't require bracing. The third topic I talked about was Metatarsus adductus, which again refers to the angulation of the forefoot bones or the metatarsals towards the midline as an isolated entity. That is to say, the rest of the foot is normal, but the forefoot is not twisted, but angled inward into adductus, which means towards the midline. And again, I mentioned that in most kids, this generally improves spontaneously and without treatment, and especially without bracing, usually by the time they're about 6 months of age. They come in three typical varieties: the flexible kind, which is completely correctable, the partially correctable kind, and the rigid kind. And there is data that shows that in kids who have persistent metatarsus adductus beyond the age of 6 months, and especially once they're starting to consider walking and even using shoes, that serial casting or even a special kind of bracing, or in some instances people have used reverse last shoes, which are shoes that are sort of on backwards, that has been notable to be helpful. Rarely do these kids ever require anything more extensive than that. But up until about 6 months, we allow natural growth and development to occur to correct this entity. The last thing that I spent some time on was painless, flexible, flat feet. Now, again, I'm going to emphasize the terminology here. The first part of the terminology is painless, meaning that the child has no complaints. The foot is flexible, which means that the arch corrects with when weight bearing is removed or when the child stands on their tippy toes. And if you want to be more specific about it, it really refers to the flexibility of the hind foot, or this joint that lives under the ankle called the subtalar joint. I didn't mention the subtalar joint the last time because it gets into a lot of technicalities, but suffice it to say the hind foot is flexible, and that is what distinguishes it from a rigid flat foot, which more often than not is symptomatic and may be an indicator of an upstream problem or a problem within the foot bones themselves. So again, when we're talking about painless, flexible, flat feet, in an asymptomatic child who is otherwise normal, bracing is not indicated. In general, I did make mention that in some kids that we might consider an orthosis or an insert in the shoe when they have pain, which is one thing we might consider, and when they're into their later childhood years. I also mentioned that in some of these kids who have a painful flat foot, that oftentimes, but that which is otherwise flexible, that sometimes they have a tight Achilles tendon, which may be amenable to stretching exercises. So we generally start with the least and then move on to the most. And in those kids that have a painful, flexible flat foot, and bracing and or stretching does not help, then we might consider surgery to treat that, and that's a topic for another day. But suffice it to say, in this instance as well, it is a option of last resort after conservative, that is to say, non-operative treatment has failed. Last thing I talked about was the transition of the alignment of the child's legs at the level of the knee from a bowed appearance, otherwise known as genu varum, where genu means the knee and varum means pointing towards the outside, or actually the lower legs towards the midline, I should say. Let me correct myself there. But it means that the lower leg is pointing towards the midline. And that generally goes from a bowed leg appearance in an infant up until the child is about 2, at which point the legs are pretty much straight up and down if you're looking at the child from the knee. And then then it continues to correct to a low point in their on that graph that I showed about the femoral tibial angle, which shows them to be knock-kneed, which is at a maximum low point or a maximum point at about age 3. So the numbers to remember are 0 to 2 is bow-legged. At 2 is pretty straight up and down. From 2 to 3, they start to become progressively more knock-kneed, or some folks have called this the X-legs. And then it goes back the other way up until about age 7, at which point you reach your adult limb alignment, where we are slightly knock-kneed. In other words, we don't have perfectly straight legs. Now, there's always a variation in the theme. That is the general sort of best fit curve, if you look at the graph, and it's sort of is the median. But obviously there are standard deviation where you get more or less bowing or knock-kneed appearance, and it occurs earlier and later in a general range. So again, this is yet another benign condition that does not respond in most studies to bracing, and which don't require treatment. Finally, the last thing I touched on was this thing called Blount's disease, or tibia vara is another name for it. Or I also briefly talked about rickets, which is usually a deficiency of vitamin D, which can lead to that bow-legged appearance. And those are pathologic bowing. So the first thing I talked about is physiologic bowing, meaning it's part of the natural growth and development of a child's legs, compared to something called pathologic bowing, such as Blount's disease or rickets, where it is actually a disease process wherein left untreated, it typically is progressive, again, in most instances, and it generally requires treatment. The reason I hummed and hawed a little bit about the treatment of bow legs with bracing is because the data and the literature on bracing for Blount's disease is a little bit unclear, and because there were some weaknesses in some of the studies where they looked at bracing in Blount's disease. But again, this is another topic for another day. So I hope that this made things clear. 4 benign conditions, 3 of which fall under the category of intoeing, all of which don't benefit from bracing, and in the natural history is one that is one of progressive improvement in most kids and doesn't require treatment. I also talked about painless, flexible flat feet, which again, you don't require inserts in the shoes in those particular children or even adults for that matter. I lastly touched on another topic of the normal growth and development of the lower limb in a child, going from physiologic bowing to physiologic knock knees to the normal appearance. I hope that makes sense. Please leave comments and questions, and let's live our best life. Cheers.